my daughter-in-law Carla.
Excellent.
Hi.
Good to
Because
meet you.
it helps me have extra
I
ears.
think it's very, very important.
Thank
So
you.
I'm an interventional cardiologist. I do catheter-based procedures, and one of my specialties is in the management of valve disease. They sent you here because you have some degree of a narrowed heart valve, and my job is to get to know you and figure out if you're having any problems with that, and what the plan is to get you better. Sound good?
Okay.
Tell me about your life. Are you pretty active? Do you get out and do things, or not so much?
Not so much anymore.
Tell me why.
No, because I just breathe heavy all the time.
How long's that been creeping up on you?
Good year.
Okay. And what kind of things will make you short of breath? Dressing and showering, or more than that?
No, more than that.
And,
But lately, it's been even just sitting.
okay, so
Then I get
Like
short.
even on the phone.
okay.
Yeah.
So minimal, like dressing and showering now wears you out.
I would say yeah, probably.
Going up a flight of stairs though, that'd be rough.
Yes.
You haven't been in the hospital with trouble breathing, have you?
No.
Okay. And did they put you on a diuretic, Lasix? Did that make you feel any better?
See now, what's Lasix?
Furosemide, 20 milligrams a day. Are you on that?
No.
Okay. You're not on a water pill.
No.
It's important for me to know.
Were you ever?
Everybody calls them different names. This is what I take. I brought now. What I'm taking now.
Sometimes I talk too fast. Let's see. That's all you take?
Yes. And vitamins.
Just those three?
Yes.
Okay. All right. Yeah, you don't take
Were
a
you
diuretic.
at one time? Did they put you on a diuretic to see if it would do anything?
I could have.
So I get a cheat sheet here with all kinds of different things that may or may not be accurate. So I just want to go through them.
Okay.
Have you ever had a history of atrial fibrillation? Does that ring a bell or not? Really?
Yes. AFib. Somebody along the line told me I had AFib.
Okay. AFib comes and goes, and it can be associated with stroke. So if you have a history of AFib, you should be on, or you'll benefit statistically in stroke reduction from being on a blood thinner like Eliquis or something like that. Has there anybody ever talked to you about that?
No.
Who was taking care of you before? Where did you come from? Have you been
Illinois.
Okay, so you just moved to the area, or when did
5
you?
years ago.
5 years ago.
About.
Okay.
Yeah.
But when did you first get
But
diagnosed?
but
with
I
it?
was with AFib in Illinois.
And why did they talk to you about a blood thinner back then?
They could have. I don't.
Okay.
I don't remember.
Was it a one-time thing when you were sick, or they just picked it up and you go in and out of AFib?
That was going in and out of AFib. He said I couldn't tell. I had no idea.
No, most people can't.
You know.
Didn't you say they picked it up on a? Didn't you say a work?
Oh right. Yeah. I was a bus driver, so I had to have yearly physicals, and that's when they found this.
So this is important because it sounds like you got blown off. And
Yes.
AFib is associated with about a 5% per year risk of stroke. That's not that high, but a 1 in 20 chance that you're going to have a stroke is a big deal. And if you don't take a blood thinner, then you miss the opportunity to prevent a stroke, which the blood thinners reduce your risk of stroke by about 80 to 90%.
I went with her to two doctor's appointments, a pulmonologist and a cardiologist, about 2 years ago,
Yes.
and they both said nothing was wrong, and both of them.
They may not have known about that AFib history. Maybe my team picked it up.
Well, they did.
Okay. I just don't understand. Something
Yeah.
doesn't make sense to me. Okay. So really what you're here for, though, is this narrowed heart valve. No dizziness or passing out, just short of breath.
Right.
Any swelling in the legs, or that's not a big deal?
Sometimes I do, but lately not at all.
All right.
No.
I spent a bunch of time before I came in here studying your CAT scan and reading through your records. So, that's
So
why I
you
know
have
a
already
little bit.
seen what
Yeah.
what was just
Just
That's
up
why
there.
days?
That's why I
We
take
wondered
time
if
to
it-
get
if
We
it.
wondered. They
Yeah.
said no, it'll be 2 days and whatever.
I mean,
so-
the official read gets done by the end of the day, but I have to go look at it
I wonder.
myself. Yeah.
Good.
So that's why it takes time, because
You
it's
want me up
hard to
there?
analyze stuff. I'll take a listen, then I like to explain things by drawing pictures. It's all very mechanical. A couple deep breaths. And breathe normal. Okay. Okay. Can you see this board here?
Yes.
The heart is a muscle. It takes blood and pumps it from the lungs to the body as your artery blood, and then back from the body to your lungs as your vein blood, where we draw blood from. The muscle part just pushes. There are valves in the heart, one-way valves that keep the blood moving forward and not backward. We're going to focus on the artery side, blood coming from the lungs to the body as your artery blood, okay? There's a main pumping chamber called the left ventricle. That's what does all the work. There's a priming chamber above it called the left atrium, and blood is pumped into the aorta, the main tube that carries blood to your body. There's no test at the end, just general concepts, okay? Blood comes from the lungs with oxygen and goes into the top chamber. The top chamber is supposed to give it a little squeeze and push it through a one-way valve called the mitral valve. That one works fine for you, so we're not going to dwell on that, but that valve opens and closes, keeps the blood moving forward into the main pumping chamber. The main pumping chamber does all the work. This pushes, this valve closes, and then it goes out the aortic valve, another valve that opens and closes and keeps the blood moving forward from the pumping chamber into the body and not backwards. That's normal, so what do you have going on? AFib is when the top chamber, instead of beating in coordination, just wiggles and jiggles. Now, today, or last time you got an EKG, it was in normal rhythm. But if it's wiggling and jiggling, there's an outpouch into the atrium that sticks out like a cave where blood clots can form. And so that's why we give people blood thinners with AFib, because blood clots can form in here and then break off and go to your brain and cause a stroke. Again, about a 1 in 20 chance per year of having a stroke. With a blood thinner, it's down to about 1% per year, so 5% to 1%. Pretty good. Best treatment for stroke is prevention. So I need to figure out a little more about this AFib history and find some documentation of somebody who's found it at some point and whether it's really true. Just because I found it on my sheet doesn't mean I commit you to a blood thinner for the rest of your life. I need to understand that you really did have atrial fibrillation, okay? Second, that's not why you're here though. You're here is because the aortic valve has become thickened and doesn't open so good anymore. So it's supposed to open and close, and yours doesn't open all the way, it only opens a little bit. Why do we know this? On the ultrasound picture you had of your heart, we can see that it isn't moving well, but we quantify how severely narrowed, mild, moderate, severe, based on the pressure drop across the valve. The greater the pressure drop, the more narrowed the valve. Why would that be? If you have a small hole, you gotta push harder to get all the blood through a smaller hole, right? Like a garden hose. Water comes out of a garden hose, you make the hole small, pressure head builds up, water goes shooting across the garden. So bigger the pressure drop across the valve, the smaller the valve. We say that a severely narrowed valve has a pressure gradient of greater than or equal to 40 millimeters of mercury. Yours was 40, so it fits the severe range. What are the symptoms associated with a severely narrowed valve? Shortness of breath. Eventually, it'll cause congestive heart failure where you fill up with fluid. It can make you have chest pain. Most people, that's not very common. Dizziness and passing out. Those are the primary. Most people, short of breath when I exert myself. There are other reasons to be short of breath. Lung disease, being deconditioned, getting older. But this is probably a real driver of your symptoms. We know that if you have a severely narrowed valve and you start having short of breath associated with it, if we do something about it, not only will you feel better, it'll keep you from getting worse and worse and worse, and it actually prolongs life substantially. This is a deadly disease. We don't think of it as a deadly disease because we have good treatments for it. Why did this happen? Parts wear out. Just your valve's been doing this 72 times a minute for your entire life. It can wear out, okay?
Yeah.
What's the treatment? There's no medicine to fix the valve. I can't give you a pill. There's no WD-40 or Drano for the valve. The valve has to be replaced. There are two ways to replace an aortic valve. Up until 10 years ago, there was only one way. Open heart surgery. Open your chest, cut this valve out, sew in an animal valve. Now, we can replace most people's valves with a procedure called transcatheter aortic valve replacement, or TAV or TAVR. So in TAVR, instead of opening you, we replace your valve by putting the valve inside of something called a stent. Stent's like a chain link fence in a circle with a little metal crown with animal tissue inside of it. That animal tissue opens and closes just like your own valve would by pressure differential. How do we get this in you? Smush this onto a catheter about the size of my finger, insert it through the leg artery, track it up through the circulation using X-ray cameras like a heart catheterization, and then we could expand the stent inside of your valve. So instead of cutting out your valve like a surgeon would do and sewing in an animal valve, we take our stent frame and push your valve open permanently, which then holds in place this fully expanded stent frame, which contains your new valve. The main advantage of that is obvious. It's done through the groin instead of open heart surgery. Most people go home the next day. Recovery, you take it easy for a week, but minimal recovery. That is not to say this is without complications. Real risk. The reason why we would subject you to that risk is because certain mortality within a few years if we do nothing. So 1% risk of death, 1% risk of a major stroke, a couple percent risk of a minor stroke, 1% risk of bleeding, which could require transfusion or surgery to fix a blood vessel, and about a 5% chance of needing a pacemaker after the procedure. So real risk, but 50% improvement in survival at 1 year. So it's good therapy. We look at you holistically. So we're going to look at your anatomy in our valve conference and have our advanced imagers look at it too. I've been doing, we're the largest TAVR program in North and South Carolina. We do over 400 of these a year between our two campuses.
You do.
We do, yeah. We are
Okay.
the pinnacle of catheter valve replacement in North and South Carolina.
Hmm.
So the bottom line is it looks pretty good to me. I think it's TAVRable, but we always confirm that by consensus. You'll also see a heart surgeon who's part of our team, not because you're necessarily getting an operation, but because we need to explore all options, and actually Medicare requires a surgeon to see you. Additionally, they're part of the implant team. Now, the catheter work's mostly done by people like me, but the surgeons are an integral part of that team that places the valve. What's next? The next step is we get the final analysis. The part that I can't look at, that my imagers look at, is the first branches of the aorta called the coronary arteries. They supply blood back to the heart to give it energy to pump. We need to make sure you don't have any critical blockages in your heart arteries. The CAT scan will often tell us that. If the CAT scan doesn't tell us that because the images aren't good enough, we may need to ask you to go through something called a heart catheterization. Heart catheterization for a little tube in the artery in your wrist or your groin, and take pictures directly of those heart arteries that give us a better sense of whether you have critical blockages or not. I can't tell you that today, but we will let you know. This is a lot to dump on you, so let me take a pause, and you tell me what you think and what questions you might have. Today is the get to know you and explain sort of what's going on and what some pathways for making you better might be.
Yeah, I had no idea it was that way.
Yeah.
Yeah. So I figured
Catheter valves probably last about 8 to 12 years. We don't really know because they've only been around for about a decade. But in head-to-head trials versus surgery out to at least 5 to 7 years, they seem to be about as good as surgical valves. Surgical valves probably last about 8 to 12 years. We just don't know. Yeah.
So with this method, she wouldn't have to be on meds for the rest of her life, would she? Or potentially?
I think there's a number of reasons why you should be on meds for the rest of your life. If you have high blood pressure, because you're on some blood pressure medicines, you need to be on those for the rest of your life because they reduce the risk of heart failure, kidney failure, stroke, death, cholesterol medicines.
Her own
appropriate.
mother passed away from stroke.
Yeah.
I had sure.
Right. Probably, if you really do have AFib and we need to discover that, you probably should be on a heavy-duty blood thinner. Beyond that, the valve replacement doesn't require any specific other medications. But if you're sort of like, I want to get off all medicines, I will tell you what you really need to do is, if you really want to live a long time and prevent a lot of bad things, you got to lose weight.
Oh yeah, right.
And that's hard, but it's like really important for you.
Yes.
Yeah, all the vascular.
But you have high blood pressure. Like I take medicines too. I don't like taking them either. But like it's better than bad things.
Right.
And most of the medicines I take and you take too are generic and are cheap.
So I think when we talked to the last doctor, or whoever we talked to, the nurse practitioner or whatever, she mentioned that this has probably caused some other heart damage.
No,
making
her
it
heart
work
still
harder.
pumps pretty good.
So
She hasn't had any damage
okay.
to her heart. It's still
Okay.
normal is like 55 to 60%.
Okay.
Heart
I
pumps
was going
55-60%.
to ask if there is damage, would it recover?
Yeah, no, her heart still pumps strong.
Okay.
I mean, if you leave this long enough, it'll cause the heart to not pump
Okay.
strong. But so far, she hasn't had any major problems with heart pumping
Okay.
function. Yeah.
Good.
I was just told that it was a valve that didn't close properly, and they just keep an eye on it. This was
That's
10 years ago.
Yeah, that's true. And ultimately, there is no treatment to keep this from progressing any more than I'm ever going to look like I did when I was 20 again. Everything ages. You're inside and you're outside. This is exactly what you'd expect if you had some early signs of aortic stenosis 10 years ago. Here we are, no shock. And there was nothing you could have done to prevent this. This was going to happen.
Okay.
And we don't treat it until you have symptoms. So do you have a severely narrowed valve? It looks like the answer is yes. are you having symptoms from that
Yes.
valve? It's classic symptoms for this valve. I don't
Yeah.
have another good explanation for them. So predictably, you should do better with this.
So you just had to wait until it got here.
That's right.
Okay, that didn't make sense to me then.
There is no
But-
prophylactic treatment for
yeah.
this. There's no prevention treatment for this.
Yeah. Okay.
So she has to. You have an appointment already to meet with the heart surgeon, correct?
To meet with a
Yeah, on the 9th,
Surgeon.
on the 8th.
Eighth.
Right.
But when it comes to the actual procedure, will you be doing that?
I can't tell you that.
Okay.
So it's a 2-person procedure, so it'll be a heart surgeon and an interventional
Okay.
cardiologist. Because we're the largest program, we do TAVRs on Mondays and Wednesdays. We do up to 5 in a day. And there's no way, given our sort of volume, that I can guarantee you that you'll be assigned to me. And to be honest with you, you just met me today. You don't know me. So it's either myself, Dr. Hill, or Dr. Schwartz. We're all super high volume, super experienced interventionists, and I operate this as a program, not as an individual. So you came to a program, not to a person. And
And where's the procedures done?
yeah, the big house, Carolinas Medical Center.
which
This
Right.
is an office
I'm not-
building. There's a big hospital, 1,000-bed, one of the top 10 heart transplant programs in the United States, right
Right
across the
across.
street.
Okay.
Yeah.
Okay. Wait, I'm not, from Denver, but I don't come down
We've
here.
only lived in
Nobody
this
likes
area
to-
like 4 years.
Nobody
so.
likes to drive in Charlotte.
Right.
People who live in Charlotte.
Exactly.
Yeah.
I couldn't drive.
This is why, you can't get this kind of care in the country. This is big hospital stuff.
So, is it basically everybody who has this done stays one night in the hospital?
Sometimes they stay longer. The minimum length of stay
Minimum,
is
right,
1
right.
night.
Okay.
It is.
So that is
It's the minimum and average.
okay.
That's good. Yeah.
Now, it could be that we say you need open heart surgery. You are not. Some people just can't be open heart surgery. You could be. 10 years ago, the only option was open heart surgery,
Right.
and you would get an open heart surgery, or you would find your way to God in your own fashion. Now we have catheter valve replacement, and I think we're probably going to offer you that.
Yeah.
But we have to make sure it's safe
Right.
anatomically,
Right.
and we will determine that as a team.
Okay.
But my
I see
own
what you're saying.
initial
Yeah.
look at it looks good.
Oh, okay.
Okay.
What
I'm
is
gonna
what
introduce-
is the I know you can't give me exact numbers, but what is the possible timeline you're looking at for
Yeah,
everything?
it's a great question. Most people we can get scheduled within 30 days of meeting me.
Okay.
Okay.
We're just kind of.
Absolutely.
You got a birthday
Yeah.
coming up. That
Yeah.
might be your birthday gift.
All right, I'm going to introduce you
It
to
will.
one of my nurse navigators who's going to be your point person and make sure that we coordinate everything smoothly and answer all your questions in the meantime.
Thank you.
All right, good. Did I explain this in a reasonable way? I've
Yes.
done this talk
The
1,000
pitch.
times,
Yeah.
like literally.
Yeah.
Okay, good. Just hang out here and she'll be right in.
Thank
Thank
you.
you so much.
Thank you.
Thank you.